Hello, this is Dr. Ed Kim. This is the second podcast in our module on cancer. And in this podcast, we're going to be going over the important semantic qualifiers when discussing and thinking about cancer. These are local, regional, and systemic. Medical oncologists, radiation oncologists, and surgeons all discuss and think about cancer in terms of these three terms: local, regional, and systemic. And I'm going to try to illustrate this by comparing and contrasting rectal cancer from colon cancer. I want you to understand that each cancer has its own specific type of spread or typical pattern of spread. But even within a type of cancer, there are individual variations. Colorectal cancer is the classic cancer in the sense that it starts out in the primary site as the primary tumor, and then over a period of time will spread to the lymph nodes, and then over an additional period of time will spread into distant metastatic sites. There are a small subset of more aggressive tumors that will go directly from the primary tumor to distant metastases. So the term local, regional, systemic is very important because it's what we use to describe patterns of spread. Sometimes there are colon cancers that are locally aggressive, invading other structures, yet when you do a metastatic workup with the PET-CT scan, there are no lymph nodes or liver lesions that light up. And then there are patients who come in with small primary tumors that already have widely metastatic systemic disease. These are systemic disease, these would be considered aggressive systemic tumors. And the type of evaluation is important in terms of defining local disease and systemic disease. So if local disease is important, you're going to want to know more about the T-staging and with greater accuracy. So endoscopic ultrasound is one modality that is used to assess local and regional spread with greater accuracy. PET-CT is a study used to assess systemic spread. And the type of treatment will also be described in terms of local, regional, and systemic. Surgery and radiation therapy are local, regional modalities of therapy. Chemotherapy, on the other hand, or hormonal or immunotherapy, are used to manage systemic disease. So these three words should become a permanent part of your vocabulary every time you talk about cancer. And one of the key ways for understanding different types of tumors and different types of cancers and retaining that information is to summarize and describe each cancer's typical pattern of spread in terms of a local, regional, and systemic. If you know the pattern of disease, believe it or not, you're going to be able to deduce the general approach to both evaluation and treatment, meaning you won't have to memorize these aspects of evaluation and treatment as separate pieces of information. Remember, you want to create a coherent narrative from which you can deduce or remember and connect the dots much easier. Because the fact of the matter is, evaluation of each cancer is tailored to address the pattern of spread, meaning pattern of spread is going to tell you what you want to evaluate with greater accuracy. And treatment of each cancer is tailored also to the pattern of spread, to address the pattern of spread. And you'll see this with the colorectal cancer differences. So colon versus rectal cancer. Well, they arise from the same type of cells. And biologically, they're fairly similar, meaning rectal cancer isn't necessarily biologically more aggressive than others. They start with the primary tumor, go to the lymph nodes after a period of time, and then go into systemic sites of spread. So let's see how they differ both in terms of evaluation and treatment based on how they behave in terms of their spread to local, regional, and distant metastases. So colon cancer evaluation requires a colonoscopy and essentially distant or assessment of systemic spread, you either using PET CT scan or a CT of the abdomen and pelvis with chest X-ray. And colon cancer basically progresses to lymph nodes and then to distant metastases. And because we have very difficulty figuring out whether there is spread to the lymph nodes, and because there is no good non-invasive way, such as sentinel node biopsy or additional imaging, surgery is required both for therapeutic removal of the primary tumor as well as diagnostic modality in terms of telling us whether there is lymph node spread, which means the patient needs systemic chemotherapy. So the colon cancer treatment algorithm goes, as we have learned earlier, that for stage 1 and 2, they go to colectomy. Stage 3, they go to colectomy. So when you first see a colon cancer patient, you really only need to differentiate stage 1, 2, 3 from 4. Because the differentiation of stage 1, 2 from 3, meaning who needs chemotherapy, is only going to be made after the operation. So before going to the operating room, all you really need to know in terms of evaluation for colon cancer is whether they have metastatic disease. And this can be done, like I said, either with a PET CT scan or a CT abdomen pelvis and a chest X-ray. Again, after the operation, the key branch point is between stage 1, 2, and 3. Because after stage between 2 and 3 is where you're going to give the patient systemic therapy because of the lymph node spread. And then before the patient, sorry, this is a little backwards, but before any type of treatment, you need to differentiate between stage 3 and stage 4. So how does rectal cancer differ in our evaluation? And this slide is not about evaluation, as you can tell. It's actually about treatment, because what's important in medicine, you have to realize, is that we don't get extra information if it doesn't change the way we manage the patient. At least most often we don't. So by knowing how rectal cancer is treated, we're going to be able to logically deduce how we should try to evaluate it, because the differences in treatment are the key points where you're going to want to know, you're going to want studies to differentiate the two different groups of patients. So for rectal cancer, in stage 1, stage 2, and stage 3, they do not all go to surgery. In fact, stage 1 and stage 2, stage 1 are the only patients that go directly to surgery. But even within stage 1, you can actually differentiate. Some people actually can just have their primary tumor removed. That's called local excision. Or they may have the bigger formal resection. Okay, and that's for T1 lesions, and for T2 lesions, you generally get the formal operation. And then after stage 1, stage 2 and 3 all get pre-op chemoradiation. So you have to be able to distinguish between this is the local excision. You have to distinguish between stage 2 and stage 1. Stage 1 and stage 2 and 3, because stage 2 and 3 do not go directly to the OR, they go to, they get chemoradiation, okay? And then finally, you need to distinguish between stage 4, obviously, because and that is the same thing as colon cancer. But as you can tell, whereas the T staging really didn't matter for colon cancer unless they were T4 and they were invading other structures, and that was going to determine your surgical approach. The T staging in rectal cancer, T1 versus T2, is actually very important. And T2 versus T3, which differentiates stage 1 and stage 2, is also very important. So the T staging is actually something that we're going to have to know if we're going to treat rectal cancer. So whereas in colon cancer, you had the colonoscopy and the biopsy, which really doesn't show you the T staging, and CT scan, which definitely doesn't show you the T staging, in rectal cancer, knowing the T staging is absolutely necessary before treatment. So that means when you evaluate somebody with rectal cancer, voila, you're going to need some study to help you determine what the T staging as best as possible. And also the end staging, because stage 3 also means that you need chemotherapy and radiation before an operation. So what kind of studies will help us? Well, that is endorectal ultrasound on the right, and this is a picture of a T1 N1 lesion. You can see that hypoechoic circular structure in one of the arrows. That's a node. Or an MRI, a high resolution MRI, in which this case, which shows a T2 N0 lesion. Okay, so you would do everything that you would do for colon cancer when you evaluate somebody for rectal cancer. But on top of that, you're going to have to find out, at least with greater certainty, what the T stage is and what the N stage is. So the local regional staging is more important for rectal cancer. And you got to ask yourself why, right? You don't want to necessarily just memorize that fact. It should make sense to you. Why does rectal cancer need more information about the local regional disease? Okay. And like I said, pattern of spread, evaluation, treatment, they're all tied together. Well, rectal cancer, if you notice, gets radiation in addition to surgery. So what does that mean? Patients that get additional treatment need that treatment. So radiation therapy is a local regional form of treatment. That means people with rectal cancer are at higher risk for having problems with local recurrence, and therefore, in addition to surgery, which is an excellent form of local treatment, they need additional help with radiation. Okay, and not all rectal cancer patients, but there are certain rectal cancer patients where the tumor may be close to where the surgical margins are. And these two pictures show how you can get positive margins on the radial edge of the tumor. And one way to remember this is that the rectum is in a confined space within the pelvis. So it's narrow and the tumors can invade out into the pelvis. And because of its confined space, it can be very difficult to get negative margins. Whereas the colon, because it's loose and free, they don't tend to have problems with local recurrence. So radial margins in colon cancer really are not a problem usually, whereas radial margins on rectal cancer are the most important margins to note. And the negative radial margins for rectal cancer, if you really need to know how close we come, are actually about 1 to 2 millimeters. 1 to 2 millimeters. So you can see that in those cases, additional local therapy to help with the margins would be very welcome, and that is why they get radiation. So in summary, I want you to understand that when you describe different types of cancer, you want to think about it in terms of how they spread locally. Are they mostly a locally invasive tumor? Local regional sometimes is a term that's used, or do they spread systemically? Okay. And by looking at the survival curves and looking at the staging based on T and N and M, you'll start to get an idea of how aggressive the tumor is and how it spreads. Okay. And the pattern of spread is going to determine the evaluation and different types of treatment. Locally invasive tumors or locally aggressive cancers will get most likely radiation. Systemically aggressive tumors will most likely get systemic chemotherapy early on or in the stages that are in the early stages of the cancer. Remember, we're comparing the baseline to colon cancer, where chemotherapy is for stage 3 colon cancer, but you will see that more aggressive tumors, chemotherapy may be instituted in stage 2 or even stage 1, depending on how aggressive that tumor is. Okay, so colorectal cancer, colon and rectal cancer, if we separate them, are similar cancers, but because of their anatomic location, one has a much higher incidence of local recurrence, and the local treatment for that cancer is more difficult, and therefore there's greater emphasis on local treatment in terms of both evaluation and additional therapy for that aspect of the disease. I hope this helps you get into the idea of thinking about cancers in these 3 terms, and we'll definitely discuss this during our classroom session with additional tumors to help illustrate this point. Thank you for listening.